Hello everyone, I'm Dr. Govind Mishra and I'll be starting this presentation on beta blockers. So as you all know, it is one of the very most important topics in pharmacology that we will be referring to shortly. Right, so we will be starting the lectures on beta blockers. So they are a class of drugs that are known to be a competitive antagonist of beta adrenergic receptors. So again, these are competitive antagonists of beta adrenergic receptors. So as we all know that beta adrenergic receptors are of beta 1, beta 2 and beta 3 types that we usually refer to. So depending on the actions performed by each of these beta receptors, these beta blockers will block the action of normal agonist of these receptors. So that's why they are competitive antagonists. They will compete against the natural agonist for these receptors. So what are the natural agonists for these beta receptors? The natural agonist will be catecholamines. Catecholamines like epinephrine, norepinephrine, which activate these receptors. So beta blockers will block the action of catecholamines on these beta receptors at different sites. Now coming to the properties for classification of beta blockers. So beta blockers can be, we'll shortly look at the classification of beta blockers, but definitely few properties that need to be considered before classifying beta blockers is their affinity for either beta 1, beta 2 or beta 3, their intrinsic sympathomimetic activity, we also refer to as ISA. We abbreviate intrinsic sympathomimetic activity as ISA. Also the property of alpha blockade. So there are a class of beta blockers that not only block beta receptors but also they have alpha blockade property. And then we have got a property of vasodilation as well. So the prototype beta blocker that we study is known as propranolol. So all other beta blockers are compared with propranolol. So that's why it is a prototype drug for this class, that is beta blockers. So propranolol, and it is classified under non-selective. So it is a non-selective beta blocker. It is a non-selective beta blocker. So what does that mean is it will have affinity for all the beta receptors, but to be very precise, the affinity for beta 1 equals the affinity for beta 2, right? So affinity for beta 1 receptors and beta 2 receptors is comparable, but the affinity for beta 3 receptors is much less than these two receptors. Now coming to metoprolol, acebutolol and atenolol. So metoprolol, acebutolol, atenolol, and also for that matter we have got bisoprolol. Metoprolol, acebutolol, atenolol, bisoprolol, these kind of drugs, they are known as beta 1 selective. They are beta 1 selective. They have a selection for beta 1, and these beta 1 selective drugs, they act, as the name suggests, they act more on beta 1 receptor subtype. So they have a selectivity for beta 1, and as we all know that beta 1 receptors are predominantly present in myocytes. So beta 1 receptors are predominantly present on cardiac muscles, myocardium. So in the cardiac muscles we have got beta 1 receptors that predominates. So that's why these class of drugs are also known as cardioselective. Beta 1 selective drugs, as well as these are referred to as cardioselective beta blockers. Again, the blockade is not absolute. Here it means that in case if you are able to increase the concentration of these drugs, they will not only block beta 1 but again higher concentrations will block beta 2 as well. So again, this blockade is not absolute, but they have a selectivity for beta 1 receptors that are present in the heart muscles. Then we have got drugs like pindolol and acebutolol. Pindolol and acebutolol are drugs that have a property of ISA. So as we have already seen in the previous slides that ISA refers to intrinsic sympathomimetic activity. As we all know, these drugs are blocking the beta receptors, but the drugs such as pindolol and acebutolol, they also can activate beta receptors partially. So partial activation or partial agonistic property of these kind of drugs in the absence of catecholamines give them a special name that is known as intrinsic sympathomimetic activity drugs. So day drugs can partially activate beta receptors as well. So what happens is when beta blockers are used, so a common side effect of using beta blockers is a bradycardia. So to prevent profound bradycardia from happening, these intrinsic sympathomimetic activity drugs are used. So these drugs, as they partially activate beta 1 receptors as well, so they will prevent profound bradycardia from happening. So these drugs prevent profound bradycardia or negative inotropy in a resting heart. We also have got another property of beta blocker, that is local anesthetic property. So local anesthetic property here means that they block sodium channels as well. So sodium blockade property is there. And we also call it as membrane stabilizing property. We also call it as membrane stabilizing property. And the drugs that are having this property are propranolol, acebutolol, and carvedilol. Then we have got labetalol, carvedilol, and bucindolol. Labetalol, carvedilol, and bucindolol, they block alpha 1 and beta. So in the previous slide where we have seen about alpha blockade property, so this alpha blockade property is shown by these drugs, labetalol, carvedilol, and bucindolol. So what they do is they block alpha 1 and beta as well. Also, because of alpha 1 blockade, they also can cause vasodilatation. So vasodilation as well as because of blockade of alpha is done by these drugs. Now, classification of beta blockers. We classify beta blockers in this way. We call it as first generation beta blockers, we call it as second generation, and then third generation. The important thing to remember here is the third generation beta blockers. They are known as third generation beta blockers because they have got a property of vasodilation. They have got the property of vasodilation through different mechanisms. So as we have seen that just shortly, we have discussed in the previous slide that beta blockers like levotalol, carvedilol, bucindolol, these beta blockers block alpha 1 receptors. That's why they are causing vasodilation. We will shortly see in the subsequent slides how other drugs cause vasodilatation. So there is different mechanisms of vasodilation that has been discovered recently. So we will go through all those mechanisms shortly. Now we have got second generation and first generation beta blockers. So first generation beta blockers, the most important first generation beta blockers, and a prototype beta blocker we discussed is propranolol. Then we have got timolol, sotalol, nadolol, phenbutalol, and pindolol. Then second generation, as we have seen that they are cardioselective or beta 1 selective. So they are also known as second generation beta blockers. And we have got acebutolol, atenolol, bisoprolol, metoprolol. Now we will discuss about the pharmacological property. The most important property that beta blockers affect is the cardiovascular properties. So it is seen that the effect of beta blockers on the resting heart is negligible, but most of the cardiac depressant effect that is evident, it occurs during exercise and stress conditions. So during exercise and stress conditions, we have got increase in the sympathetic activity. We've got increase in the sympathetic activity, lot of catecholamines in there. So increase in the catecholamines levels. So when there is an increase in the sympathetic activity during stress or exercise or any other disease state, then this cardiac depressant effect of beta blockers is much more evident. So overall, summarizing the cardiovascular effects on the heart for beta blockers. So these points are the most important, and they summarize most of the effects of beta blockers on cardiovascular system. The first one is a negative chronotropic effect. So negative chronotropic effect refers to, as you all know, it's decrease in heart rate. Then we have got negative inotropy. So negative inotropic effect means decrease in contractility. Then we have antihypertensive effect. So we'll discuss this antihypertensive section separately. How this antihypertensive effect is brought about by beta blockers. Then we have got decrease in the cardiac work and oxygen consumption. So there is decrease in the cardiac work and oxygen consumption. So this is a property that is made use of by in conditions like angina. So why beta blockers are effective in conditions like angina is because they restore the oxygen supply and demand balance. So in angina, as we all know, there is decrease in oxygen supply and there is increase in demand. So what beta blockers do? Beta blockers will decrease the oxygen demand. So the oxygen demand will be decreased by beta blockers, or they decrease the oxygen consumption. And what is the determinant of oxygen consumption? Determinant of oxygen consumption is heart rate and aortic pressure. Aortic pressure. So heart rate and aortic pressure, this product of heart rate and aortic pressure is decreased by beta blockers. So that's why they reduce the oxygen consumption or the oxygen demand, and they are useful in conditions like angina. Then we have got coronary blood flow. So again, beta blockers will lead to blockade of beta 2 receptors in the coronary arteries as well. So it will affect the vasodilatation of these arteries, and it might decrease the blood flow in coronary blood vessels. But again, as far as the coronary blood flow is concerned, the coronary blood flow is decreased only in subepicardial region, and subendocardial region is not affected. So subendocardial region is a region which is affected by angina. So again, angina per se is not affected, or the region that will be affected by angina will not be affected, that the subendocardial region won't be affected. It is only the outer region of the myocardium, that is subepicardial region, that will be affected by decrease in blood flow. Then we have got stabilizing heart rhythms. How the beta blockers will stabilize the heart rhythms is by decreasing the AV conduction, atrioventricular conduction. So decrease in AV conduction is achieved by use of beta blockers. That's why they are effective in conditions like supraventricular tachycardias, because they do not allow the supraventricular rhythms to pass on to the ventricles by decreasing the AV conduction. So they decrease the AV conduction. And also they are used in heart failure, because in heart failure they enhance the survival in heart failure and decrease cardiac remodeling. So in heart failure they tend to decrease cardiac remodeling. So we have got short-term versus long-term administration of beta blockers. So as we have all seen that beta blockers have got a negative chronotropic and negative inotropic effects that will lead to decrease in cardiac output. But what happens is there is an increase in total peripheral resistance if the beta blockers are used for short term. So why this increase in total peripheral resistance is encountered? Because using a non-selective beta blockers will also block the beta 2 receptors, which are responsible for vasodilation. So because this vasodilatory beta blockers are beta 2 receptors are blocked, so the action of alpha 1 receptors is not controlled. So alpha 1 receptors will because of catecholamines, alpha 1 receptors will cause further vasoconstriction that will lead to increase in total peripheral resistance. Right? So initially, while using beta blockers for short term, we have got increase in total peripheral resistance because of blockade of beta 2 receptors. But once these beta blockers are used for a longer term, total peripheral resistance returns to normal or is reduced. So the reduction in the blood pressure that is achieved from the use of beta blockers is by the use of these beta blockers for long term, that on long term use reduces the total peripheral resistance. Now we have got drugs like bucindolol, labetalol and carvedilol. Bucindolol, labetalol and carvedilol, as you have already seen in the previous slides, that these are known as, these drugs also have a property of alpha 1 blockade. Alpha 1 blockade. So they also block alpha 1. So as this increase in TPR initially was due to alpha 1 activity, but by the use of these drugs, even the alpha 1 action will be blocked and you can find a much greater fall in total peripheral resistance. So you will find mostly these kind of drugs with alpha blocking property being used as antihypertensive medications. So it causes a greater fall in total peripheral resistance. Now coming to antihypertensive effect. So antihypertensive effect is achieved by blocking renin release from the JG cells of the kidneys. So renin release, so we have got JG cells in the kidneys, we have got receptors of beta 1 receptors. So these beta 1 receptors, if they are blocked, so renin release is inhibited. And also action on presynaptic beta 2 receptors. So what happens is, these presynaptic beta 2 receptors, presynaptic, they normally stimulate the release of norepinephrine. So norepinephrine release is stimulated. So more of the norepinephrine is released. So what these beta blockers will be doing, they'll also block these receptors, that is presynaptic beta 2 receptors, and that they will inhibit this release of norepinephrine. That's why they will be effective in hypertension. Again, antihypertensive effect is achieved by long-term administration. Now coming to effect on cardiac rhythm, as we have seen that they decrease the AV nodal conduction because of increasing the refractory period in AV node. So what is refractory period? The refractory period is the period after which the response to the second action potential is achieved. So this refractory period is prolonged. So as soon as the response for the first action potential is there, then there is a longer gap after which only the AV node will respond to the second impulse. So this increase in refractory period is achieved by the use of beta blockers. And also they decrease the rate of spontaneous depolarization of ectopic pacemakers. So if there are some ectopic focus developed that are generating impulses, so these ectopic focus impulses should be blocked before they are transmitted into the ventricles. So for the blockade of these ectopic impulses and preventing them to pass on to the ventricles, we have to block the spontaneous depolarization of this ectopic focus. So this ectopic focus spontaneous depolarization is again blocked by the use of beta blockers. So they are very effective in AFib and supraventricular tachycardias. Okay, so as we have also talked about the special property of beta blockers, that was vasodilation, and I told previously that there will be different mechanism of this vasodilatory effect. So we have got different properties like nitric oxide production. So vasodilation can be achieved by nitric oxide production by these beta blockers. Then we have got beta 2 receptor agonism. So beta 2 receptors are responsible for vasodilation. So beta 2 receptor agonism is also shown by some of these beta blockers. Then we have got alpha receptor antagonism, alpha blockade property. We have already seen drugs like labetalol, carvedilol, and synderolol. Then there is also a mechanism that is calcium entry blockade. So this calcium entry blockade is also achieved by drugs like betaxolol and carvedilol. Then we have potassium channel opening. This is done by drugs like tilisolol. And then there is a special property of antioxidant property that is shown by carvedilol. Okay, so now we have got effect on exercise. The use of beta blockers in exercising heart. So what happens in exercise? Exercise, we have got higher levels of catecholamines. Higher levels of catecholamines mean increase in heart rate. So catecholamines will cause increase in heart rate and increase in contractility. But what will happen? In the presence of beta blockers, as we have seen, that beta blockers cause a decrease in heart rate and contractility. But it is seen that during exercise, if we use beta blockers, there will be no reduction in cardiac output. So the cardiac output won't be affected. Why is it so? So because cardiac output is a product of heart rate and stroke volume, beta blockers are causing a decrease in the heart rate, right? So decrease in the heart rate is caused by beta blockers, but compensatorily this stroke volume is increased by the body. So body increases the stroke volume to compensate for the decrease in heart rate. How the stroke volume is increased? By increasing the venous return to the heart or by increasing the end diastolic volume. So the end diastolic volume increases, also venous return to the heart increases. This increases the stroke volume. So the overall effect is uh, cardiac. Overall effect is that cardiac output is not decreased. Right. So effect on exercise of beta blockers is that there will be a reduction in heart rate but no effect in cardiac output. Then we have got exercise performance is impaired. So definitely exercise performance is impaired. Yes, because beta blockers will be blocking beta 2 receptors as well on the blood vessels. So beta 2 receptors are responsible for vasodilatation. If they are blocked, no vasodilatation and less blood flow to the exercising skeletal muscles. So if the blood vessels in the skeletal muscles are not dilated enough, then definitely blood flow will be reduced and oxygen supply will be reduced. So again, exercise performance is impaired by the use of beta blockers. So overall, there is decrease in the heart rate, there is no effect to the cardiac output, but there is decrease in the exercise performance. Okay, so again, another property of beta blockers is buffering effect of catecholamines during exercise. So what happens in this case? During exercise, if this is a exercising muscle, during exercise there is efflux of potassium from the exercising muscles. Now to prevent that hyperkalemia state to happen, catecholamines like epinephrine will cause an influx of potassium into the exercising muscle. So again, during exercise, it is a state where higher sympathetic activity is increased. So the activity of epinephrine will be there, and this epinephrine will cause the influx of potassium into the exercising muscles. Right. So this is how the epinephrine buffers the state because exercise will cause efflux and epinephrine will cause an influx of potassium. Now, if the beta blockers are used, if the beta blockers of E is used, this buffering capacity is inhibited. Then epinephrine is not able to influx the potassium, and this buffering capacity of catecholamines is lost with the use of beta blockers. Okay, so we will continue with some of the pulmonary effects in the next part of this lecture. So, if you have any queries, you can just ask me in the comment section, and we'll continue with the rest of the beta blockers in the part 2 of this lecture. Thank you.